necessity is about alignment. It's the intersection of what a clinician believes a patient needs and what the clinical evidence supports, and also what the payer will actually cover. So from a provider's perspective, it means, is this service reasonable and appropriate for this patient at this time based on their condition? From a payer's perspective, it means, does the diagnosis, documentation, and context meet our coverage rules and guidelines? So where organizations tend to have issues with this is when those two perspectives drift apart. The care may be clinically appropriate, but if the diagnosis selection, the documentation, or the timing doesn't align with the payer policy, that service is deemed not medically necessary, and it often results in a denial. So practically speaking, medical necessity isn't just about a clinical decision or a billing rule, it's a communication problem. It's about clearly telling the patient's story in a way that both clinicians and payers understand and agree on. When that happens upstream, you reduce denials, rework, and delays in patient care. Clinical judgment alone is not enough for reimbursement because a lot of the guidelines dictate exactly what must be documented. So as a provider, their documentation alone that their clinical judgment provides that this should meet medical necessity doesn't align with payer policy guidelines or criteria. So the payer policy guidelines are based on evidence from peer-to-peers, or peer-reviewed documentation, from best practices. So we want to make sure with payer guidelines that clinical judgment comes into play, but it's just not the best indicator of what's covered. You have to look at those payer policies. The documentation gaps that tend to lead to most medical necessity denials tend to be procedure and diagnosis mismatch. And the way that we look at those, we see a lot, the actual policy, the payer policy, dictates which procedure and which diagnosis are approved for those procedures. So for example, Keytruda is a cancer treatment drug that we see a lot of denials for. It's approved for a narrow list of diagnosis coverage. So if you use that drug and you use a diagnosis of acute cystitis, that's not going to pass medical necessity because that's not an approved treatment for that. So we see that mismatch a lot, and that leads to a lot of denials and rework on the provider side. Lab and diagnostic services are denied so frequently because of a high volume of incorrect diagnoses that don't support medical necessity for those ordered services. So lab and diagnostics, they seem to be a super high volume in provider practices. And if you think every time you go to a provider, they may decide to order labs for some reason to evaluate something. We see a lot that the diagnoses that are added to those charges are usually like an encounter diagnosis. So the encounter diagnosis is something like a routine encounter. So if you're here for a routine encounter, that really doesn't meet medical necessity for labs for vitamin D evaluation or for a thyroid panel. So we see a lot of denials based on that just because you're at a routine provider visit, they order a diagnosis of a routine visit, and that really doesn't meet medical necessity for those services ordered. Medical necessity ties into audits and compliance risk because our documentation and our orders should all match. We should paint a picture. So as a provider, one of the things that I would always look for as a compliance director was, does this chart paint a picture of what happened to this person during this encounter? So for their care, we should really have documentation to support the diagnosis that we're providing, the treatment that we're providing, and then the services that we're ordering. And that all should tie together to ensure that medical necessity is met and that compliance risk is alleviated.